and learning so much about kidney disease and directly from two of our members, Tamara Smith and also Monica, in terms of talking with us about their own experiences. And this is exciting. The National Coalition of 100 Black Women is an advocacy organization that is on behalf of Black women and girls. And we look to the areas of health, education, and economic empowerment. We really do believe that without health, we have nothing. So tonight's session is really just paramount to that belief. And we're looking forward to it. So we just want to say to you, thank you. Soak up everything and all of the information. I especially want to say thank you to Tamara and Monica for sharing their personal stories, and to Dr. Scantlebury and Santana in terms of lending their expertise for the night. And we also have on the line with us our president, Melanie Spikes Daniels. And I'm not sure if Melanie would like to give some words, but if so, she can do so at this time. Thank you.
Thank you, Sharice. I will be very, very short. Thank you again to all that are attending. A special thanks to Dr. Scantlebury, Dr. Santana, our co-chairs, Tamara Smith and Monica Shockley Porter, as well as our ever so evident and capable contractor, Sua Afusu. Thank you so much for all of the work that you all have done collectively as a group. We are so happy to provide this information and this discussion, and I look forward to all that will come out of it. You can take it away.
Thank you, President Daniels. I am Asua Ofosu, and I do also lend my thanks to all of our program participants, as well as their speakers for this evening. It should be a very informative and engaging conversation. And I, for one, look forward to gaining much more knowledge from our presenters. But before we get started, I want to talk a little bit about the Beyond the Mask initiative that is from the National Coalition of 100 Black Women Delaware chapter. It is an initiative to raise awareness and provide resources and educate Black women and girls about overcoming and getting beyond COVID-19. In addition to, and the website is beyondthemask.info. And in addition to providing resources for COVID-19, it also provides information about jobs, mental health, housing, and other resources that you may need as we all navigate through COVID-19. So I also want to give you one quick update about vaccinations here in the state of Delaware. Beginning yesterday on March 17th, pharmacies in Delaware began vaccinating individuals that were 50 years and older. And they also provided vaccines for individual patients that are 16 and older who have high or moderate risk of medical conditions. So basically we want everyone to know, if you would like to be vaccinated and you're 50 years and older, please sign up at pharmacies or talk to your individual physician. Beginning on March 23rd, the state's vaccination hotline or portal will be open for people to sign up to be vaccinated. And so in addition to that information, on the website beyondthemask.info, there is information about vaccines, places, and other things that are available for those who need information about COVID-19. So now I will turn it over to Dr. Santana to introduce our speaker.
Good evening, ladies. I will be introducing Dr. Velma P. Scantlebury, MD, FACS. She is the Associate Director of the Kidney Transplant Program at Christiana Care. She accepted a position at Christiana Care after working at the University of South Alabama's Region Transplant Center, where she served as Professor of Surgery, Assistant Dean of Community Education, and Director of Transplantation. She has been named to both the Best Doctors in America and Top Doctors in America's list multiple times. Dr. Scantlebury earned her medical degree from Columbia University in New York City. She was an intern and resident in general surgery at Harlem Hospital Center in New York City. She completed her fellowship training in transplantation surgery at the University of Pittsburgh and then joined the University of Pittsburgh School of Medicine as an assistant professor of surgery in 1989. She rose to the rank of associate professor prior to her appointment at the University of Southern Alabama in Mobile. Dr. Scantlebury's special interests include researching the end results of donation and transplantation in African Americans, increasing organ donation in the African American community through education and awareness, increasing the incidence of living donor education and transplantation by education, and treating viral infections in kidneys. Ladies, let's give Dr. Scantlebury a warm National Coalition of 100 Black Women welcome tonight.
Thank you so much, Dr. Santana. And I want to add that I no longer work at ChristianaCare. I have retired and passed on from ChristianaCare to doing my own thing. So thank you so much. Appreciate that. So tonight we will continue. I want to say greetings to President Melanie Daniels and Sharice Brewington Carr, our VP, and as well as all the members of the National Coalition of 100 Black Women. I thank you for attending this informative session, which I hope you will find intriguing. Ask your questions in the chat. I think there's one, yes, there. And so we will begin by continuing our conversation that we had a month ago on kidney disease.
Really quickly, would you like to get into the poll before you get started?
Oh, yes, thank you. Go right ahead.
Okay. All right, let's see if we can get this right this time. All right, the first question that we have is, are you considering becoming a living kidney donor? That's our first question. And you can select your answer. The second question is, are you or someone you know in need of a kidney transplant? The options there are yes, I need a transplant, yes, I know someone in need of a transplant, or no. And then the last question is, are you a transplant recipient, yes or no? So I'm going to launch the poll.
Okay. I guess I should say, all right, would you be willing to become a living donor? Because,
okay.
Okay, so let's make that, yeah, would you be willing to become a living donor?
Okay. So would you be willing to become a living donor? All right, and I see individuals answering the poll. We'll give it a few minutes. We're about halfway there. Still a few more. We'll give it a few more seconds for everyone to make their selections. All right. I think we can go ahead and end it. Are you able to see the results?
Yeah, so most people are undecided when it comes to considering being a living donor. Interesting. And about 6 people know someone in need of a transplant. And there are no transplant recipients in our audience today. So thank you so much for answering those questions. So I will go ahead and share my slides. And we will talk a little bit more about kidney disease treatment. But what I will do is also give you a summarize what we spoke about last month. See if this will show. Okay. There we go. And so one of the things that we wanted to remind you about is to know your facts about your kidneys. Know where they are, which is 2 bean-sized organs, each the size of your fist, which is basically in your back. And so your kidneys regulate your blood pressure. And so it's important to know that if you didn't have kidney disease before, as you develop kidney disease, you will develop symptoms of high blood pressure, because as the kidneys become damaged, it makes it difficult to control your blood pressure. So not only is high blood pressure a cause of kidney disease, it's also a symptom of kidney disease. It's also important for vitamin D, activating vitamin D, producing the hormone that makes red blood cells and keep us from being anemic. It reduces waste, they reduce waste products and filter water out of our system and keep us in good balance. So it's important to know that there are estimated 37 million people in the United States that have some stage of chronic kidney disease. And most of them, 90% of them, don't even know that they have kidney disease. Why it's so important to know your numbers. And 1 in 2, or every other person with very low kidney function, may not know, may not be on dialysis and may not even know they have kidney disease. So it's very important to get your numbers checked, as it is generally silent. So kidney disease is really, once your kidney stops working, you may have an acute injury. Let's say you were in a car accident and you injured your kidney, there was blood in your kidney. We know that if your kidney function may be damaged, but that will improve over time. And so when you have an acute damage to your kidney, the fact that that may be due to blood loss or dehydration, you can generally fix that issue and recover your kidney function. People who have COVID disease and were admitted to the ICU are often affected with kidney dysfunction. Some patients require dialysis because of the issue of the viral infection in the kidneys, but generally the majority of them will recover and not need long-term dialysis. However, the difference is chronic kidney disease, which we can go from normal with increasing risk kidney damage over time, reduced kidney function, and then gradually various stages will get you to what we call kidney failure. And so we call these various stages. We're at stage 1, you're about 90% of your kidney function, and that's most of us who get over the age of 60. Generally, kidney stage 2, you're down to about 60 to 90% of your kidney function is still going well. Nothing usually to worry about unless you're very young. But this usually happens with age, which means that, as we get older, our kidneys may not be in the greatest condition to donate. Once you get past 70, we generally would not take a kidney from someone in their 70s, because the question is how much function will they be left with behind, and do they need both of their kidneys to continue to live their life without chronic kidney disease progressing rapidly. So once you get to stage 3, it's mild to moderate with less function. And by the time you get to stage 4, you're down to 15 to 30%. Most people are listed for dialysis when they get to about 20%. And at 20% or less, you're then evaluated for possible treatment options, because then that's usually at the point of no return. So what are the common causes of kidney disease? Diabetes is number 1, with about a large percentage of patients on dialysis having diabetes, but then high blood pressure is seen in the African-American population and being number 1 for African-Americans. And then we have a whole host of other diseases: polycystic kidney disease, drug toxicity, sickle cell disease, sarcoid, lupus, drug abuse, and a whole host of all others. And you see from this pie graph here, certainly the majority of people are going to be diabetic and hypertensive. And those who are diabetic soon later on become diabetes plus hypertension as they develop kidney dysfunction from diabetes. They go hand in hand. We know there's ethnic disparities in end-stage renal disease, with African Americans 3.5 times more likely to develop kidney failure from chronic kidney disease than Caucasians. And so will Hispanics also develop 1.5 times more likely to develop kidney failure. Native Americans, this is generally due to diabetes. And so African Americans progress faster from a stage 2 or 3 or 4 quickly to stage 5, needing dialysis and being overrepresented in most dialysis centers. And so when we look at this data here, we see that when we look at the relative stage of kidney disease, 1 to 3, which is chronic, could be doing okay. These are in red, you're Caucasian and white, Black still not too bad, and Hispanics a little bit less. But then the prevalence of going on to stage 5 or end-stage renal disease needing treatment is 4 times greater if you are African American. So this is an issue that we need to really recognize and be willing to also take our family members or all the members and the friends to remind them to get the kidney function checked, because this is often a silent disease. And when you adjust the incidence of end-stage renal disease by race, you find that per million African Americans in this top line are really outnumber all else across the board. Symptoms of kidney disease can be mostly silent. By the time you have symptoms, you may be in severe end failure with accumulating a lot of fluid. You're swelling in your legs, can't get your shoes on, shortness of breath, low blood count and anemia, just really tired all the time, having memory loss, or what we call is brain fog. And sometimes, for us as women, we just assume we're working too hard or we're eating too much salt and don't generally associate these things with kidney disease. And so unfortunately, kidney disease, most people may then be diagnosed with chest pain or congestive heart failure because of the fluid accumulation, only to find that that's a symptom of kidney failure. So when we management of chronic kidney disease, you want to make sure that you reduce your risk, which is associated with complications of heart disease, acute kidney injury, chronic anemia, having buildup of acids in our bodies, as well as bone disorders. So it's important to target your blood pressure and make sure that your blood pressure is well controlled. For those with chronic kidney disease, especially with that protein in the urine, which generally is with most diabetics as they develop a chronic kidney disease progression, the use of ACE inhibitors or angiotensin blockers. These are specific blood pressure medicines that help reduce and protect the kidney once you have high blood pressure and protein in your urines. If you're diabetic, it's important to monitor your hemoglobin A1C and also adjust for nutritional therapy, seeing a dietitian who can help you with diet and regulation. MinuteForYourKidney.org is a website where you can spend a minute to test whether or not you are at risk for kidney disease by putting your numbers in. You need an email, and they will email you back your risk of kidney disease and perhaps stage. So just write that down, MinuteForYourKidney.org. So when we do this, when you take this test, this is, are you in that 33%? 33% of those of us in the United States are at risk for kidney disease, but most of us don't know it. And having kidney disease puts you at risk for, we know, complications of COVID, and we're well aware of what we've seen over the past year. So take a minute to find out if you're in that 1/3, 33% of those who may be at risk for kidney disease based on diabetes, high blood pressure, or underlying heart disease. So we're going to switch to treatment of kidney failure and what we call end-stage renal disease. And so this is when you get to the point of stage 5 and there's no longer an option for saving your kidneys. And you're basically accumulating metabolites in your system. If you think about the fact that if your kidney function is at 15%, that means 85% of your metabolites and your waste products are now being retained within your body, which will make you sick, which will give you trouble remembering, tired, fatigue all the time. Not to say the anemia, because now your kidneys are not able to make that enough hemoglobin because of lack of erythropoietin that is generally made from the kidneys to help regulate your anemia. So you are so tired from all the waste products building up in your system, and then you're anemic, so you're not getting enough oxygen carrying capacity, so you're panting. And so after a while, your doctor decides based on your symptoms whether or not you are just can't tolerate it, you are sleeping all the time, and you're afraid that your brain may suffer, you may get a stroke or a heart attack based on the stuff that's accumulating in your system. The options are dialysis or transplantation. Now, there are two different forms of dialysis, what we call hemodialysis, and this is where your blood is filtered through the machine, is connected to a vein and an artery, and it then filters your blood to take out those metabolites that you're now no longer able to pass out in your urine. While you may still be making urine while you have kidney failure, it's just not putting out the things that it needs to. So it's important to know. Patients say, but I'm still urinating. Well, it's just wasted water that has nothing, that's not containing the waste products, because your kidney can no longer do that. So the machine will have to do it for you. The other option is peritoneal dialysis, where a catheter is placed within the peritoneal lining of your stomach, and the dialysate solution, which is made specially to allow for transudation of metabolites across your peritoneum, that is instilled. It sits there for a period of time, and then it is drained out. And so you do this cycling of fluid in, fluid out over. Usually you can do it at night over the course of sleeping, and at home once you're trained adequately in a dialysis center. And this allows for more mobility. You can still continue to work because you then have your days free. And so the risk here is only making sure you're clean and making sure there's no catheter infections that will then get inside your abdomen. But it allows for less diet restrictions, and most people maintain good urine output that allows for better volume control. And so you don't have the restrictions of fluid as much as you do with hemodialysis. Once you start hemodialysis after a few months, and some people even immediately, your urine output diminishes. Your body says, I don't need to work this hard anymore. And you then have very little output. And so everything you drink accumulates in your system. And just imagine if you could not urinate, how much you would gain during the course of a day if nothing comes out. So this is what leads to heart disease, because you are then creating a system of a whole lot in 5-6 pounds of fluid, 7 pounds of fluid during the day. And then you're waiting 2 days to de-dialyze off that volume. And so that's sitting on your heart and your cardiovascular system, then playing havoc until it's done. And then you repeat the cycle all over again. Then there's the option for kidney transplant, deceased or living donation. And so these options, and one of the disparities in healthcare is for us as African Americans not being presented with these options from the beginning. We're late usually in the course of being diagnosed with end-stage renal disease because we're not on top of our game, or doctors have somehow missed it. You're given blood pressure medicine. This is a story I hear all the time. Well, I took my medication, so my blood pressure was better, so I felt I didn't need them anymore. And so 5 and 8 years later, you're then diagnosed with kidney failure because of hypertension, because you didn't feel it, you didn't think you needed it. And that's why high blood pressure is called the silent killer, until someone develops a stroke or heart attack, which then leads to recognition of, oh, you have significant hypertensive damage to your blood vessels, to your kidneys, to your heart. It becomes a shock for that system. So a lot of patients are diagnosed in the emergency room, late stage, without having that pre-knowledge about transplantation. If you know you're stage 3 to 4 or getting to stage 4, you can begin to gain that information that would allow you to think about, well, maybe I can avoid dialysis. If I have a living donor, then this person can be worked up and be ready to undergo donation, so that the recipient then is receiving a kidney instead of going on dialysis. But that takes planning, that takes knowing that you're getting there. And so that makes it important to understand the course of your disease, know where you're headed in order to get there. So that becomes important. There are benefits to transplantation. Dialysis can only do about 15% of what a normal kidney does. And so fluid is its biggest problem, especially with hemodialysis. Once you lose that urine output, you have very restricted to what you can drink, because it's going to play havoc on your heart. And so you have to follow a very strict regimen. Yes, you can do it. I know people who've lived on dialysis for 15 years, 20 years, and they've done it because they felt that this is what they were better off doing. And so the problem is that one of the things with dialysis is the lack of ability to make that hormone to keep you from being anemic. And so your hemoglobin tends to be really low. Unfortunately, for many people, it's required to keep your hemoglobin greater than 9, which for most of us is about a hematocrit of about 28, 29. And so you're constantly always anemic because there's no benefit based in the world of nephrology to bringing that hemoglobin up higher. And so for transplant, we know that most people who receive a transplant, as far as a normal kidney, especially a living donor kidney that's been worked up, we know they don't have any underlying high blood pressure or diabetes. We know the kidney function is normal, and that one kidney will continue to work and function appropriately over time and increase in size, so that there are many people who, despite having one kidney, will do better than 50% of kidney function, and over by 6 months to a year, they're up to 85 or 90% of what a normal kidney would do, because that kidney compensates for just being alone. And the person donating the kidney also will benefit, because that kidney remaining, once they're cleared medically, will also compensate from being in the body alone. And instead of working 50%, it will increase so that the donor will continue to do well. People who get a transplant, once you restore normal kidney function, even though you may have one kidney and you may typically be in stage 1 or 2, that's okay, because now you're not restricted as much in terms, and you can drink more freely. The people who are on dialysis for many years and have they restricted to let's just say a liter a day, 1,200 cc's a day. Now you're asking to drink 2 liters a day, and they're saying, I can't do this. I've done this for so many years. There's no way I can drink more. And then there's those who cheat and have been drinking a lot all along, and it's no problem for them. But those who get transplant will have more energy because their anemia will go away. They can get back to work. They're no longer tied to the dialysis machine. So life becomes normal again for them. We know also that survival is better after transplantation. We see here in this graph that when we look at patients on dialysis in red, in blue is deceased donor transplant, and in red and green living donor transplant. So at 1 year, certainly you're going to do better. A certain 30-35% of people would die in the first year after transplant, but with deceased donor transplant and living donor transplant, you're going to do exceptionally well. The difference is at 5 years, a significant number of people would have died on dialysis at 5 years, compared to those with deceased or living donation transplant. And at 10 years, just about 10% of people on dialysis will be alive at 10 years. So this is where transplantation definitely gives you a better long-term survival for the average patient on dialysis. Now we know that there are over 100,000 people on the waiting list for a transplantation. Over 90,000 of those are waiting kidney, with those distributed across the rest of the other organs. But mostly the need is going to be kidney transplant. And we know that there's not enough organ donors out there. Excuse me, patients on the waiting list versus those transplanted. When we look at kidneys, this is the need, this is who received. And we know, so therefore, many patients will die waiting for an organ. And it's important because when you look at African Americans, the need is also great for both, much more for Caucasians, but proportionately, your Caucasian recipients will receive a kidneys twice as much as African Americans. So we definitely need to be able to think. We don't want our loved ones to die on the list. We want to be in agreement with organ donation, and we want to think about living donation. So donors must be in excellent health, and we hear about that in a minute. We know you have to have 2 kidneys in order to donate 1. Some people are born with 1 kidney, and therefore they come forward and you realize you have 1 kidney. Sorry, you can't be a donor. And so the option now is most of these operations are done laparoscopically, and recoveries generally 2 to 4 days, and most donors are able to get back home. So we're going to have a conversation about living kidney donation. And so I'm going to stop sharing my slides and we'll then turn to our conversation on living donation. So thank you very much. I hope there, so who is going to start the chat for us?
I will. Thank you very much, Dr. Scantlebury. We learned so much from your presentation, and I have a lot to do in terms of looking for a minute for your kidney.org to get some information. So I do thank you for that. We will now have conversations with two living donors who gave their kidney or donated their kidney. And we want to hear their personal story and in their own words, what it was for them and their decision making and how it is their experience as a living donor. I will first introduce you to our two speakers. The first person is Tamara Smith. She is the Executive Director for Teach for America Delaware region. And the second speaker is Monica Shockley Porter, who's Director of Community Relations for Dover Behavioral Health System. They are both members of the National Coalition of 100 Black Women and serve as co-chairman of the program committee. So I will start with my first question to you both is, what made you decide to become a living donor?
Thank you. So I'll kick us off. Hi, everyone. Good evening. What made me decide to becoming a living donor was pretty simple. My sister, my younger sister, was in need of a kidney transplant. She's 4 years younger than me. And unfortunately, similarly to what Dr. Scantlebury shared, didn't realize she was in a kidney failure until she was rushed to the emergency room at age 21. My sister was a varsity athlete and amazing health, and the onset of her kidney disease, which was IG nephropathy. I think I'm saying that wrong, Dr. Scantlebury. It came on all of a sudden. She went into instant renal failure, and within 48 hours, we discovered that she needed a kidney transplant. And so as her sister, I was the best match and went through a series of tests to make sure that I could be a donor, and happy to say that I was. But the decision was pretty simple for me. I wanted to make sure that my sister had the best chance just to continue a long, healthy life.
Awesome, awesome.
Thank you. Monica, the same question to you.
Absolutely. So situation was very similar to Tamara. So I ended up being a living kidney donor to my sister, who was diagnosed with FSGS. It was more of a gradual transition and progression with her kidney disease. It wasn't a very quick decision. Tamara talks about like a quick turnaround for deciding that she wanted to donate. I had a lot of factors that I needed to consider. I was a wife, I was a mother, so I had to talk with my husband, I had to talk with my family. I talked to all of them before even bringing the idea to my sister. So I wanted to just make sure that my family was on the same page, because you only got two kidneys, right? So I knew if I donated one, if my husband turns around and needs a kidney 10 years later, then there is no other kidney to give. So, we made the decision as a team that it was what I wanted to do. He was okay with it, talk with my daughter as well. And then I presented it to my sister, who was still a little resistant at first about accepting it. So again, it just took time for us. So it was a pretty drawn out process of a lot of testing over a little over a year time period.
Thank you. That kind of leads me to my second question is like, what was the process? How long was the surgery? How long were you in recovery? What your experience as a living donor, what was that?
Yeah, it's a great question. As Monica said, there is a period of time of testing. Mine wasn't quite a year, but about, I think like 6 to 8 months, similarly for mine. Doctors want to make sure everything is set and all in place before you go through such a procedure. And while I believed I was healthy, I didn't think I was at my peak health. You know, there's always something that you feel is wrong. And I think that was my biggest concern, was that I wasn't going to be approved, even though I was younger. I was 25 at the time, but I was. So there was a period of testing. And then the actual procedure itself is pretty long, but of course you're knocked out for the entire procedure. I remember being wheeled into the surgery room, I think sometime around 1 o'clock in the afternoon. And I was awake until they, of course, put the anesthesia, and then opening my eyes in the recovery room around like 7 p.m. or something along those lines. There was a huge clock on the wall, but of course you're not, you know, aware of any of those things. So in the hospital for about 4 to 5 days, and then at home resting for another 7 days, able to move around, all of those things. But of course, because it is a major surgery, I didn't go back to work. I was a teacher at the time, so it worked perfectly for me. Had the procedure, it was in May. And so I just stayed at home and recovering as well. My life post-surgery has been no different. I'm often asked, you know, like, do I feel different? Have I had to make adjustments in my lifestyle? I have not. I've only had to adjust things that I would need to adjust, whether I had 2 kidneys or 1. So, you know, healthy eating, all of those things, and being aware of that. But I sometimes forget that I only have 1 kidney, and I'm only reminded when I see on my abdomen my 2 little marks from the transplant itself. But my life is still the same. The actual procedure itself, again, like I said, the recovery really was not bad. The worst discomfort I felt was in the first 48 hours in the hospital, which I was told about that from my assigned nurse, from my surgeons. The way they described it was, when your body comes out of the anesthesia, it's going to be working overtime because it's going to realize something is missing. And so the discomfort that you feel is your body trying to figure out what that is. And your sister is going to be up on her feet. And sure enough, literally the next day after the surgery, my sister came down to my room. We were at Penn with her IV pole, and she's grinning and smiling, and I'm laying in the bed just a little sore and uncomfortable. Wow. But she was up and about, and she had been on dialysis all that time. So that was a blessing to see that. And again, like I said, my life post-surgery, it's now been, like 15 years. My life is no different. My life is great. And my sister is still healthy and thriving as well.
Wonderful. Monica, I'm going to switch over to you for another question. And you can address the question that Tamara did, but my question to you is, did you have like a support group or someone to talk to as you were thinking about going through with the kidney donation? And then afterwards, what was that like for you?
So before she answers, I want to add something. I don't want to scare people into thinking that the whole time she was having surgery that long. But one of the things that's important to realize that when the donor is put to sleep, when they're knocked out within that first hour, there's a lot that goes on after they're initially put to sleep. And so the actual surgery will usually not begin for a good hour later because it's positioning. You are the healthiest person in that hospital undergoing an operation that you don't need. And so the goal is to make sure that you don't drop your blood pressure, that you, because you were not eaten anything from the night before. So generally as a healthy person, not taking in any water, your blood pressure is low. So they have to hydrate you up. Then they have to shift you and position you and get you ready, and then get you prepped and be in the right position, and then coordinate with the anesthesiologist. So then if you're in there at 1 o'clock, you're usually asleep, and that incision may not start after all the IVs and tubings are placed. And so it may be a good 2 o'clock before you're done, or 2:30 before that incision is made. And then when you wake up, the surgery may end at 5:30, but then you are not awake, or they may not have extubated you by then, and then you have to get to the recovery room. And so there's a good hour and a half before you're out of things to be able to realize that you're in a recovery room. So the surgery itself, usually, especially laparoscopic, is going to be no more than 3 hours, but it makes it seem like there's a lot of time. So I'm not scaring, we don't want to scare those people who might have been donors, want to consider donations.
Thank you so much, Dr. Scantlebury. All I know is I went to sleep and woke up. That's all I remember.
I'm sorry, Monica, again, the question were, did you have support groups before and after the surgery?
So yes, I try to educate myself as much as possible because this was a process that we were going through, a lot of testing. So I actually linked with the Kidney Foundation where I was living. I went to a lot of their trainings, talked with other living donors and folks who were already in the process of becoming living donors. Also leaned on my church for support, my parents, my extended family, and also it was something special that my sister and I were going through together. So we leaned on one another because, you know, we both had some anxiety and, you know, just some nervousness leading up to the surgery. And my experience is much like Tamara's and how she talked about her recovery. And I can remember going down to visit with my sister after the surgery and just seeing the life come back into her. It was amazing, like just to see her skin look so fresh. It just felt like it was a wonderful feeling. It's one of the best feelings other than like how you feel when you give birth to a child. I mean, it was that amazing feeling to see that and know that you made that difference.
Wonderful, that's great. That is absolutely very, very good. I just have one other question, but if any other, and we have questions that are in the chat, so we'll leave it open to the three of our presenters to answer those questions in a moment. But my final question to our living donors are, what advice would you give for those who are considering to be a living donor? And I'll start with you, Monica, and then go to Tamara.
I would say to research and find out as much as possible. There are so many things that are circulating, so much misinformation out there regarding living donation. Just educate yourself. And I think the more that you educate yourself about it, the more comfortable you will feel about it. My quality of life has improved because I take better care of myself because I, know that I have one kidney and I'm aware of that. So the things like, the things that I used to eat or the things that I used to do, I'm just so much more aware. So I think that it actually improved my quality of life.
As well said, Monica. I would just add that please research. There are a lot of rumors and misconceptions about being a living donor out there. And I would even just add just being an organ donor in general. When we all pass on, lots of rumors around that as well. It's one of the proudest things, that I've done. And like now that I'm 15 years out, if there was a way for me to do it again for someone else, I would gladly do it. I would just encourage folks to do research, again, for your own, comfort and understanding, but just recognize that, as Dr. Scantlebury shared, we make up a large portion of those who need organ donations. And we unfortunately just do not necessarily sign up or agree to. So I would just encourage everyone to do your research, ask questions. I'm always more than willing to speak and answer questions and talk about it, be a living organ donor or also just be an organ donor in general, have that added to your license. And that's all I would add.
Very good. Thank you very much for your personal stories, giving us your insight. Many of us have probably dealt with someone we know on dialysis. For me personally, my aunt and uncle were both on dialysis, and my uncle received a kidney from his son, so he had a living donor. So we've all, not we, I think all, but most of us have the experience dealing with kidney disease. So we thank you both for telling your stories. And again, thank you, Dr. Scantlebury, for being just our expert for kidney disease and transplantation. We did have one question or two questions in the chat. One question is for, I guess would be for Dr. Scantlebury, is should we monitor our creatinine level?
Most definitely. I think that should be part of our panel as we go to our physicians and knowing your numbers. The information, I tell people, know your blood pressure, know your cholesterol, Know your hemoglobin A1C if you're diabetic. Know your creatinine, and know if you have protein in your urine. Often your creatinine may be normal, but you may be spilling protein in your urine, which is an earlier sign that there's something wrong. And for the patient who had FSGS, oftentimes that could be likely missed because of the protein in the urine or IgA nephropathy. Sometimes before the creatinine changes, we will have protein in our urine. So that's the very important key. And the issue is, oftentimes when I go to my doctor, I have to insist that they check my urine, because generally they send you for a blood test, but they forget to give you a urine test. So now that we can go get our blood work outside of the doctor's office, always make sure that they're checking that. So that's very important.
That's good to know. Thank you.
Yeah.
And another question was, if you have stage 1 diabetes and you are on medication to maintain your diabetes, would that not lower your chances of being affected by kidney disease?
As long as you control your diabetes and keep your hemoglobin A1C within that normal range, which is less than 7, and not allow that blood sugar to diabetes will slowly lead to what we call a plaque disease. So it's not only just blood sugar and diabetes, you got to make sure that your blood pressure is controlled. You have to make sure that your cholesterol is controlled, and that your all those things together, that what are the other factors that can lead to complications and problems that will make your diabetes worse: smoking, obesity. So it's just not one simple thing. And so it's about getting everything. It's about having that healthy lifestyle and lowering your risk of heart disease, because it's really like it's like a tier where diabetes may be up here, but there's so many other factors along with diabetes that will lead to heart disease, and and kidney disease. And so those things are important, because ultimately it is this destruction that comes to your fine blood vessels. And so those are key to know. You don't want to build up. You may control your diabetes, but if your cholesterol is out of whack, you're still losing the battle.
Thank you. I do have a couple of other questions for you. Why is it that the disparities among African Americans and whites are so different in terms of not only getting end-stage renal disease, but also the opportunity to get the transplant?
Well, we know that for African Americans, our blood pressure is more difficult to treat. Oftentimes we require 2, 3, 4 medications to treat blood pressure. And because our blood pressure often doesn't come along with symptoms, we see a lot of folks not thinking they need their blood pressure medicine, because we all don't like to take medicine. And so our blood pressure goes out of whack. You go on vacation or you go away and you forget your blood pressure medicine and you think it's okay. So many times I get on my family, you got to take your blood pressure medicine with you. Don't forget it, because the times that you don't have it, you're putting yourself at risk for worsening and progression of your disease. And because it's a silent disease, we tend to feel it's okay to skip a dose here and there while it builds up in our systems across the board. It's more difficult to treat. And now we know that African Americans are associated with a genetic APOL1, where we know we can be either monozygous or dizygous for this APOL gene, which puts us at risk for high blood pressure. And while in Africa is a gene that protects you from getting malaria, and it also adds to higher incidence of high blood pressure. So now we're testing if people have high blood pressure at a young age. We want to know, do they have this gene? If you're just a carrier, it doesn't put you at risk for kidney failure. But if your spouse has it and you have kids and they both get that gene, then they're at risk for end-stage renal disease due to high blood pressure, or more likely to do that. So that you may have that genetic inheritance. So whether you want to be tested or not, if high blood pressure runs in your family and you're getting it at a younger age, maybe something that, and it's not environmentally induced, you change your diet. That's one thing to consider. So that's when you see your nephrologist and that specialist who is going to monitor and take care of your blood pressure, you want to make sure that that's at least addressed. We unfortunately progress more rapidly from stage 1 and 2 to stage 5 as African Americans because their blood pressure is more difficult to treat. And therefore, when we get there, we're without preemptively having the opportunity to know that you're getting there, you end up acutely being diagnosed because you knew you had high blood pressure or kidney disease for the past mild kidney disease for the past 5 or 10 years, and suddenly you're at stage 5 and need acute dialysis. And oftentimes the message is not delivered in a way where your options are being told appropriately. What are your options? Can I get a transplant before? Generally, you're told you need dialysis. And so many patients are not given that option for transplant, are not given that information. So it's really about knowing, educating yourself on the choices, educating your family, and even saying to your doctor, well, what about transplant? Should I be considering that? And that's so key, because we know that there's implicit bias, and there's healthcare disparities in physicians within healthcare, even in terms of who they treat, who they deem worthy of receiving a kidney transplant. And we know that very few African Americans get transplants without going to dialysis or even getting that information. And so it's important to know your disease process and have that advocacy from your physician to point you in the right direction.
Wonderful. Thank you very much. We are going to be ending soon, but I just want to let everyone know that your stories and your information has been invaluable. We appreciate it and we thank you. And there's one other question I see just popped up in the chat. As a 25-year-old African-American woman, what should I be on the lookout for that I wouldn't usually be tested for? So I think the question is, besides the normal things, is there something specifically that African-American women should be tested for?
We want to make sure we know our numbers. We want to make sure that they're not just checking your blood pressure and checking your heart rate and sending you on the way. All of us need blood. All of us need a full panel at least once a year. And if you're 25 and you have a history of high blood pressure, diabetes in your family, you want to make sure you're checking for protein in your urine. Our gynecologists used to do it, but they may not be doing it anymore. If you're doing that at GYN and dipstick in your urine, make sure that you ask them if there's protein in your urine. Sometimes the doctor's office, but if you go to LabCorp or getting a blood work done someplace, make sure that there's a checklist, a check mark on that lab slip for checking your urine also.
Wonderful. Thank you very much. So as we close, I want to thank you all for your presentation. Dr. Scantlebury, Tamara, and Monica, you all were just wonderful. And thank all who were attending. And I want to also let you know that if you were taking notes like I was and you missed something, don't worry about it. This program is being recorded, and it will be up on the Beyond the Mask in the National Coalition's website by tomorrow. In addition, there will be a evaluation that will be sent to all the participants who registered. So we would really like for you to complete the evaluation when you get it. It will help us in a long way in terms of the future programs that are being planned by the coalition. So now I will turn over the last closing comments to Ray Jones Avery, who is the immediate past president of the coalition, and she is also the project lead for the Health Equity Project. So I will turn it over to Ray for closing remarks.
Thank you. Thank you, Dr. Scantlebury, Monica, Tamara. Were your sisters acknowledged?
No, can we spotlight them?
There she is. That's my sister, Allison Simon. Go ahead, Allison.
Okay, that's Tamara's sister, Allison. And where's your sister, Monica?
I don't believe my sister is on the line today. I don't see her name listed, but
Okay,
I'll send my love to her from you guys.
Okay, thank you. Just wanted to acknowledge you. It's got a little happy soul.
Awesome, thank you.
How miraculous is this experience that we were able to take a sneak peek into this evening. So inspirational. It's just tremendous. We just happened to be talking one day, and Monica has shared a little bit about her story, and Tamara, but they didn't know about one another. And the creator brought them together in a leadership role in this organization, and it is not happenstance. So
Yeah.
thank you. And I imagine that you will get additional opportunities to share your story and for us to be guided by Dr. Scantlebury. So this is really a tremendous opportunity. Please visit Beyond the Mask, or you can go to ncbwde.org. There's so much information on there. The main thing that I want you to know is that starting next week, the next age grouping, 50 and up, will be eligible for to be vaccinated. And we do anticipate a big rush like we did in the very beginning. So if you go onto the website, the information is there. The links are there for you to register through a pharmacy or through the government site. And we just want to make sure that brown and Black people are taking advantage. Dr. Scantlebury, do you want to underscore that in any way?
Absolutely. I think it's so important that we really stand up for each other. We really got to support each other and do what we can to enlighten each other about our choices, knowing that our healthcare system, we know that there's racism out there in all levels, and it does not skip any of the establishments. And so that's a certainty. And so we definitely need to do what we can to support each other.
Thank you. So the information is the information is there, and share it with others. It's very these things are popping up, no notice, unless you're in the information chain. Many people do not know what's going on. So please share the information as you get it. And we want to thank our funders, Newcastle County Government, the county executive, and the Office of the Governor Communications Department for making these programs possible.
And make sure if there's an elderly person in your anywhere where you live, or know someone who cannot get to these sites and can help them out, pass the word, because we're still not accounting for those who are not technologically up to date or can maneuver the system. And that's a tremendous bias when it comes to the discrepancies that are out there and why we're still not getting vaccinated at the same rate. So we definitely need to, they need to be intentional, but we're not as intentional as we should be.
Thank you for pointing that out. So we do have 65 plus members of our community that are not online. They're unaware. There are many people that want it. They just don't know how to get started or what to do. So there are thousands of people in that age group that still haven't been vaccinated.
Absolutely. It's just there's a big void, and I've been trying to figure out how we can fill that gap, but yeah, it's not happening.
It's one person at a time.
Absolutely.
So call all your people up, see if they're interested. Have they made their choice? Do they need information? Do they need, as Dr. Scantlebury said, do they need you to register them? Do they need a ride? What do they need? Okay.
Yeah.
All right. So I think that we're ready to close out. Allison, I don't know if you wanted to say anything. We did acknowledge you. I don't want to put you on the spot, but I also don't want to hit this leave button. Well,
I think this has been definitely an informative session. I think it's great that you all had this. I did thank Tamara again, for being a living donor. It really changed my life. A lot of things that were said as far as the protein in the urine. Sorry, excuse me, he just wants to be seen. As far as things as protein in the urine, those are definitely things I experienced, and I was followed by urologists, but ultimately, like Tamara mentioned, and I was very healthy too. I was playing soccer and in college, and that's when I got sick. And the kidney disease came all of a sudden, but I'm grateful that God blessed me with my sister, like I said, to give me the kidney, and it's an ongoing joke now. If she asked me to do something and I'm like, no, she's like, well, I gave you a kidney. But just a lot of things that were touched on were very true with the protein in the urine. Like I said, that was big for me. That did show up earlier, but they didn't catch anything at the time. So yeah, I just wanted to, echo everything that was said, and, thank you all for having this program.
Thank you.
Absolutely. And
Thank you.
I'm going to end by Britt saying for specifically time and time over again that I have seen young people, teenagers, young athletes being sent to urologists because of protein in their urine, who then work up their kidneys and say there's nothing wrong anatomically with the kidney. Urologist looks for something abnormal to fix, but you can't, and you need to go beyond that. And so they're said, you're fine. We don't see anything wrong. You don't have a tumor. You don't have anything going on that I can see on the scan wrong with your kidneys, but the intrinsic fact of kidney disease was not picked up. And while they were told that, then 5 years later or 3 years later, they're coming down with acute kidney failure. And we see that so many times in our athletes who they're then diagnosed with FSGS, or those diagnoses that are missed because there's no pathological diagnosis for the protein in the urine. And so if you have young people, young teenagers, young sons especially, get on board and make that something that you constantly make sure your doctor checks him or her.
Okay, all right.
I didn't mean to cut, that's exactly what happened. I was followed by urologists for 2 years, and then 3 years later, when I was junior in college, that's when everything just happened suddenly.
Mhm.
Yeah.
Thank you. Thank you again, everyone. If you have teachers or people that work in the school system, related personnel, Dr. Scantlebury, Dr. Coker, and their colleagues are doing a session on Sunday at 4 p.m. The information is on our website. And so that's again, free and open to the public. The conversation is targeted for educators. Anyone can join. So if you know educators that are hesitant, that have questions, that's the session for them. So be well, take care of yourselves and others, and have a great evening.
Take care and thank you so much.
Mm-hmm.
Good night, everyone.
Thank you. Good night.
Good night.
Good night.
Good night, everyone.
Good night.
Good night.